Hello, everyone. My name is Zaara Rasheed, and I'm going to be a junior at Skyline High School this upcoming fall in Sammamish, Washington. So today I'm going to be presenting my research on interleukin-13 receptor alpha 2, or IL13 Ra2 for short, CAR T cell therapy for glioblastomas. So the agenda for today, I'm going to go over some background information, then I'm going to be presenting my research on this treatment. So what is a glioblastoma, also known as a GBM? It is a malignant tumor that forms from the astrocytes in the central nervous system, CNS. Now, astrocytes are the most abundant type of glial cell in the central nervous system where GBM tumors initially form. Some characteristics of GBM is that they rapidly progress. As you can see in the figure on the top right, that was the size of the tumor in December of 2002, and only 3 months later, in March of the following year, the tumor had progressed that much. There's also a high chance of recurrence of GBM tumors, which means if you surgically remove the tumor, there is a high chance that the tumor will regrow in another area of the brain or CNS. Some common symptoms with GBM are headaches, seizures, troubles with vision, balance, and speech, depending on where the tumor is located. So what is CAR T cell therapy? CAR T cell therapy is a type of immunotherapy where patients' T cells, or their immune system cells, are genetically modified, adding a chimeric antigen receptor, or the CAR, that detects a tumor antigen and kills cancerous cells. A tumor antigen is a protein found only on tumor cells that can be used as a target for immunotherapy, such as CAR T cell therapy. So these are two different diagrams representing the same process, but this is how CAR T cells are made. So you start by collecting the patient's blood, then you use a machine to separate the T cells. Then you take these T cells to a lab and genetically modify them to have a chimeric antigen receptor. You multiply the T cells and you deliver them back to the patient. So there are many ways of delivering them back to the patient. You can do it intravenously, so in the patient's veins. You can do it intracranially, so directly into the patient's cranium, or intraventricularly, which is into the ventricles of the brain. So this is what actually happens when the CAR T cells come into contact with the cancerous cells. So the chimeric antigen receptor binds to the tumor antigen on the cancer cell, and when it binds, it activates the CAR T cell. Now, this activation releases toxins into the cancerous cell, ultimately killing the GBM cell. So how is the interleukin-13 receptor alpha 2 tumor antigen involved? So this specific tumor antigen is present in 75% of GBM tumors, and this CAR T cell therapy, specifically interleukin-13 receptor alpha 2 CAR T cell therapy, can target a large population. So in figure A, you can see there's a molecule called interleukin-13 receptor alpha 1, and it binds to a protein called IL13. So when these two bind, a series of events happens, and it ultimately results in apoptosis, which is natural cell death. But in figure C and D, IL13 Ra2, or the tumor antigen, it also binds to interleukin-13, except when these two bind, there is no result of apoptosis. Now, this is a problem because IL-13 has a higher affinity of bonding with interleukin-13 receptor alpha 2 than IL-13 Ra1, which makes the tumor not only more invasive, but it also makes apoptosis not occur. So my objective through this research is to examine the efficacy of interleukin-13 receptor alpha 2 CAR T cell therapy to control the progression of glioblastomas. My methods of research were reviewing existing literature through PubMed database and clinicaltrials.gov. I searched for keywords like CAR T cell immunotherapy, glioblastoma clinical trial, and chimeric antigen. This is a flowchart that shows my process of research. So I initially started with 492 results searching for CAR T cell therapy in glioblastoma. Then I made it more specific by adding clinical trial. I had 82 results, and finally I searched chimeric antigen and got 36 results. So this is the landmark study that I'm going to be basing the clinical trial results on. So in 2015, there was a case study conducted by the City of Hope. They focused on a patient, a 50-year-old male, who began his CAR T cell therapy 6 months after being diagnosed with GBM. He previously had traditional cancer treatments such as surgical resection, radiotherapy as well as temozolomide chemotherapy. And this treatment was conducted in 3 phases over a course of 220 days. So these were the patients scanned before the treatment began. The treatment began on day 50, and you can see the patient had 5 different tumors in his brain. Tumors 1, 2, and 3, you can see how they've continued to progress over a course of 21 days. Now, tumors 1, 2, and 3 were actually surgically removed before the treatment began, but tumors 4 and 5 were left. Now, these are the patients scanned after cycles 1 through 6, or phase 1 of the clinical trial. The CAR T cell therapy infusions were delivered intracranially through a catheter, which ended up in the cavity of tumor 1, which had been removed. So you can see that tumor 1 actually didn't continue to progress, but in the cavities of tumors 2 and 3, which were also resected, two new tumors formed, tumor 6 and tumor 7. Not shown, but tumors 4 and 5, which were not removed, they continued to progress as well, and tumor 8, which formed in the spine. So this is a table just showing all of the new tumors that formed, whether they were previously surgically resected, and where they are located in the central nervous system. So now, after cycles 1 through 6, the researchers realized that intracranial delivery of these CAR T cells was not effective because it was only affecting local tumors, but it wasn't reaching out to the other tumors in the CNS. So they decided to deliver the CAR T cells intraventricularly. So this means that they delivered it into the ventricles of the brain. The ventricles of the brain are where the cerebral spinal fluid is created and transported throughout the entire central nervous system. So theoretically, if you infuse the T cells into the ventricles, they would be able to move throughout the entire central nervous system and target all the forming GBMs. So now, in the early stages of the trial with intraventricular delivery, you can see the significant change in tumor growth. I want you to focus specifically on tumor 8 because it's most visible. You can see the tumor in the spine, in the lumbar spine specifically, and how it pretty much disappeared. So tumors 4, 5, 6, 7, and 8 were left, and they each decreased by about 77 to 100% each. So this graph kind of shows what you saw through the scans. The x-axis is the days after enrollment, and the y-axis shows the tumor size. You can see that the intracranial delivery of the CAR T cells wasn't effective because you can see the tumor size start to increase. But then once the intraventricular delivery began, the tumor size decreased exponentially. If you focus on these top 3, tumors 6, 7, and 8, you can see they decreased by about 300 millimeters squared each. Unfortunately, this treatment didn't work as well as the researchers had hoped, seeing as after the treatment, 4 new tumors recurred in the brain. These tumors, though, were located in different regions from the previous 8 tumors. So a little summary of the clinical trial. Intraventricular delivery was much more effective than the intracranial delivery. After phase 1, or cycle 1 through 6, the trial, there were 5 tumors, 4, 5, 6, 7, and 8. 8 was the only one located in the spine. After cycle 16, or the end of the treatment, the tumors decreased in size significantly, as you saw through the graph, and unfortunately, 4 new tumors did form at the end of treatment. So what are some challenges that these researchers faced with CAR T cell therapy? So one is antigen validation. This is making sure that the CAR T cell targets the correct molecule. In the picture we saw earlier, we want to make sure that the CAR T cell targets interleukin-13 receptor alpha 2, not interleukin-13 receptor alpha 1, which is found on normal cells. Tumor heterogeneity, which means we want to make sure that the patient's tumor expresses that tumor antigen and it expresses it enough for the CAR T cell to be effective. The immunosuppressive tumor microenvironment. This is the tumor's environment to secrete substances that can suppress the immune cell response from the T cells. And finally, CAR T cell exhaustion, which is the T cells become quickly dysfunctional after chronic targeting of the tumor antigen, and they lose their ability to fight cancer cells. So in conclusion, interleukin-13 receptor alpha-2 CAR T-cell therapy has not been a very effective treatment for GBM in the long run. Although I'm excited to see where this immunotherapy treatment will progress over the next couple of years, but some questions for the future. Will combining interleukin-13 receptor alpha-2 CAR T-cell therapy treatment with other traditional cancer treatments improve glioblastoma outcomes? And can future CAR T-cell therapies target more than one tumor antigen at a time? These are my resources. And thank you so much for listening. I want to say thank you to all the fellow interns who made this experience amazing for me, Dr. Pierre, who helped me with my research, to all the faculty and visiting physicians who came and spoke with us over the course of these 3 weeks, and my family who listened to my presentation constantly. Thank you so much, and are there any questions I can answer?
So we're going to open up the floor for questions from the audience or the online. Can you state your name and ask your question?
Yeah. So first of all, I just want to congratulate you on a phenomenal presentation. Question for you, did you know anything about this 3 weeks ago? How did you become an expert in such a short period of time? And where do you see yourself in, 15, 20 years?
Wow, that's so first of all, I had no idea what CAR T-cell therapy was. I barely knew what a glioblastoma was. So this this program has provided me with so much information and so much guidance on how to do research. I kind of just looked through all the published articles on CAR T-cell therapy, and I watched YouTube videos to learn more about it. And that's how I kind of figured out that I was interested in it. In 15 years, I do see myself as I see myself as a surgeon because I was very interested in it. I'm not sure about neuro, but I think I want to do research as well. So maybe being an MD PhD, but because I've heard a lot of surgeons as well as researchers who have done that over the course of this program.
Any other questions? I don't have the Zoom link active. Is there anyone online, Ben? Okay, great. All right. Again, you did a phenomenal job explaining that, learning it in such a short time, and again, talking about the limitations of immunotherapy thus far. It is a great avenue to explore for future research, and I know you even spent time talking to Dr. Cobbs,
Yes.
who's one of our tumor neurosurgeons, specifically related to. He does a lot of research as a neurosurgeon scientist and has a lab, and so he's even gave you good insight and
Yes.
feedback on that. So again, thanks for your work. Okay.